logging on today. See if you're gonna see less likely, but still possible on them, but they're not with the common ailments. Hey, good afternoon to you as well. Report it, and there are side effects, meaning that that's the case. And you're doing well out there. Really well. All right, so it says I have good connection now. Let me just adjust my camera here a little bit. All right. So now I can see the questions a little bit better. So now hopefully I won't be interrupted anymore. I have not the best connection for cell service out here. So I was talking about COVID versus the flu. So I came across information today about the way that mutations can occur and the differences between COVID and the flu. So initially I started out talking about vaccinations and how there was no natural immunity and no vaccine to COVID-19 when it first started out. So that was the major difference between that and the flu, and why it was basically no innate immunity anywhere and it could spread through basically anybody could be a potential host. Now we have vaccinations and we're getting closer and closer to herd immunity, but we're still quite a ways away, at least in the United States. And for other countries where they're seeing breakthrough cases, they're not seeing increases in death. They're seeing breakthrough cases, as we would suspect, about 10% of the population might become infected, even if they've been vaccinated. But the complications are far less for those that are vaccinated versus unvaccinated. Oh, sorry, can I move? Yeah, so I'll run through this real fast. So for allergies, you're not going to see as much fever, body aches, and you're not going to have a loss of taste and smell. And shortness of breath is in an asterisk, most likely because if you have allergy or asthma and it's associated with your allergies, that could contribute to shortness of breath. Or if your allergies are very severe, it could affect your breathing. But for the most part, you won't see those things. Now with COVID-19, you may have a sore throat, unlikely to have some of the other stuff, the sneezing and watery, itchy eyes, and then less likely chance for a stuffy nose. So that's kind of how to differentiate between allergies and COVID-19. But back to the flu versus COVID. So with COVID-19, we have a setup for the mRNA, and there's ways of looking at it. There's a 5' end and a 3' end. Now for COVID, basically the mRNA that shows up from the vaccine or from the virus itself are in a scenario where they can literally enter your cell and replicate. And that is a bad thing in the sense that it can start to replicate sooner, but it's a bad thing that it can replicate sooner, but a good thing in that it reduces the chances for mutations. So versus the flu, where there's a 3' to 5' orientation. So what happens is it has to be reverse transcribed to make the next RNA sequence to then be able to produce what it needs to produce. Both viruses are single-stranded RNA. Now, when you have the reverse for the flu, because it has to go through the reverse process first, that introduces a chance for mutations. And then once it's able to start replicating in your body, you now have replications that are occurring and you're introducing mutations. So essentially, the flu has an increased ability to mutate by chance alone. You got to remember, viruses are not thinking of mutating. It's the fact that the mutations are occurring by chance alone. And unfortunately, the new thing is the new strain might be more virulent. So it keeps telling me to move my head. All right, I'll see if I can move myself down here a little bit so you all can see. Sorry, it's kind of hard to get out of the way from the graphic. Let me see if I just scoot myself down here in the picture. There. Is that better? I'll just stay out of the shot here a little bit. So that way you all can see the screen. But basically, with the flu, we see mutations every year, and the fact of the matter is, the previous year's immunity as well as the vaccine are unlikely to be effective. So, with the COVID, luckily we haven't seen that level of mutation. We've started to see some changes. The vaccine's slightly less effective, but still very effective, and we haven't seen a very major mutation like we see with the flu, which basically happens every single year. So far, let's say COVID has been out for 18 months, which if the first cases were December of 2019 or January of 2020, then you can imagine that we've been at about the 18-month mark now. They may have been out around before that, but we haven't seen a major mutation to the point where the accepted vaccines right now are no longer effective at all. So let me go ahead and see if we can start answering some questions. So what are the questions? So the leaky vaccine theory, that came around because of a study that they did in chickens. And even within their own study, they said that it's unlikely to have any merit in humans. And then there was a follow-up study that said that it doesn't transfer to human, or that the idea doesn't transfer to humans of this leaky vaccine, or where basically mutations can occur without people knowing they're sick, and they're going to be prone to creating a new variant. The thing is, whether you're vaccinated or not, you're going to have that going on. The main thing about the vaccine now is that it prevents severe illness and strain on the healthcare system, as well as suffering and death by patients. So that's the main thing. How about the droplets? So from the beginning, this is considered respiratory droplets, which are, your major droplets that are coughed out, sneezed out, things like that. Now, can smaller droplets potentially allow that to happen? Things that are in normal talking, less likely, but usually it's more forceful things, sneezing and coughing, and larger amounts of secretions of droplets to allow that viral load to infect somebody. Um, let's see here. So the long-term effects. So uh, the good news is for long-term. So point blank, if you're talking about somebody who's had a vaccine for 5 years, we don't know that. But from the non-living vaccines and the COVID vaccines and non-living vaccine, we've never seen somebody all of a sudden have a problem 5 or 10 years down the road. And also, we've had people with the vaccine for over a year now, and we haven't seen any new occurrences of things. Usually, the stuff that happens early on, the minor side effects, allergic reactions, etc., will show up very early. So that way, you're aware of what's going on sooner, and you're unlikely to have a random long-term effect that happens. 99.8% chance to live if you're healthy and no conditions. That varies greatly depending on your age. Even healthy 65-year-olds can have a 5% mortality rate, overall mortality rate, which includes healthy, unhealthy, and all ages. For our country is about 1.7%. Let's see here. What about the success of other treatments? So Regeneron and some of the monoclonal antibodies look to be promising. Remdesivir seems to be helpful to reduce the amount of um, viral replication. I know that there's mention of Pfizer coming out with an oral um, medication to help those that have become sick with the illness. This is for after you've been infected. I don't know how, they're very early in trials. We don't even know if it's going to pan out. They've had some promising information, um, but we still don't have much more information about that. Why is the second dose making you so sick? So it's hard to say why one dose makes somebody more sick than somebody else, because there's people that get an immune response more robust to the first one versus people that have a more robust response to the second one. And likely your immune system responding to the vaccine and kicking into gear, making antibodies and everything like that is why you're starting to have a fever, mild aches and pains and everything like that. For me, it was the second shot. For other people, I know it was the first shot, and then for some people, they didn't get a reaction at all. So it's going to be dependent on how your immune system responds to the vaccine. I'm going to go ahead and push this back down here. And if people need to see it, I'll move out of the way. Um, ivermectin and doxycycline. So unfortunately, those haven't been shown to be effective. Now, have people taken those, and likely in the beginning of an illness when they were likely healthy and not going to be hospitalized anyways and recovered? Sure. But all of the high quality data that we have suggests that these are not effective. And the reason we have to do the research is to know that we're not going to be doing more harm to individuals with side effects. And we have to remember that about 80+% of people will be mild disease or asymptomatic. At least that was older data from the Alpha variant. It might change some as we have more people that start to experience the Delta variant. But with ivermectin and doxycycline, we just don't have the data to support giving that out. And we practice evidence-based medicine because we don't just go out and use anecdotal evidence of somebody used it and they did well, because that's how you end up harming more people than good. Because relying on one person's response to a medication, one, doesn't tell you that that medication was responsible for recovery, and two, you might be putting others in undue harm's way by putting them on medications that haven't been shown to work. So the Mu is a new variant. It's under the World Health Organization as a variant of interest, which is one of their lower. It's not even a concern. And then the highest level is a variant of consequence, which is one that's very worrisome. So these other variants are things that are being monitored, but they don't think that it's going to be terribly a mutation that's going to lead to significant changes, especially regarding the vaccine and contagiousness and mortality. How long should you wait till you get the booster? So right now, the only recommendations for immunocompromised individuals, and but if you are would really like to have the booster shot, the other recommendation is that for somebody who's had their previous shots greater than 8 months ago, because that's when we start to see some decrease in antibodies. Everybody's different, just like with natural immunity, which can work great. We don't know how long the immunity will last in every single individual. So 8 months is likely when people would starting to get the booster shot to help with their immune status. Yeah, so one Cleopatra, yes, I'm vaccinated. I had the Pfizer shots. My first one was in December of last year, and then the other one was January of this year. So I'm coming up on the 8 month mark. And being somebody who's intubates patients, and we do take care of COVID patients that come for surgery, I would probably consider getting the booster shot for myself, and and that way I can protect myself, but also my children at home that aren't vaccinated. I don't want to bring anything home when I could have tried to protect myself better. Yes, I could bring it home and spread it, but at least it mitigates my risk the best I can. In addition to wearing surgical masks around the hospital and N95s when I'm doing aerosol generating procedures, such as intubating patients. Patrick P. Daniels. He's a puppet. So I'm here just giving out information on my own. I don't gain anything from this, and nobody's telling me what to say or do. So you people can say what they want, and that's fine. I said that from the beginning. I'm here to answer questions from whoever has questions about it. Big Pharma doesn't pay me anything, actually. I've told everybody this before. I'm sure you've cycled through and maybe haven't seen me before, and that's fine. I don't own any stocks in any of the companies that do testing or vaccines or any of the treatments. I might have some stocks through index funds and retirement plans, but I don't own any individualized stocks in any of these companies. And also, I'm not being paid. I make some money as a content creator, just like everybody else from my regular videos, but I don't make anything from the live sessions. So Carly 360, cardiomyopathy, asthma, high blood pressure, fully vaxxed with Moderna. Should I get the booster now? You were vaccinated in March. The recommendation would be 8 months. So likely, obviously, always check with your healthcare provider who's taking care of you. But likely, your recommendation would be sometime in November. You shouldn't likely need it before that point. And even if you get to that point, you might not necessarily need it unless you're also immunocompromised or on any medications that might compromise your immune system. You're less likely to probably need it that early. You might need something down the road, or if we get more data that suggests people do need it at 10 or 12 months. And I don't want to say 10 or 12 months and people think that means an annual vaccine every year, but that might just mean that that's enough to get us through this infection to get it under control where it becomes endemic, kind of like the flu, but hopefully not to that level. And we may or may not need booster shots, but nobody can tell us that for sure. But hopefully we don't need annual booster shots because of how slowly the virus is mutated compared to the flu. Let's see here. So long-term effects with children. So again, this kind of the thing about the children that they were mainly concerned about was the myocarditis, so inflammation of the heart muscle. And the one thing they're investigating right now is the dosing. So they're hoping that the adult dose, the 30 microgram vaccine dose, typically, if they cut that down, they're checking different dosing regimens, but they're hopeful that 10 micrograms will be enough to allow for immunity without causing problems and limiting the chances for myocarditis. So that's the main thing that they're trying to work on for the kiddos. Now, for long-term effects, they're probably in the same boat as the adults in terms of the vaccine doesn't stay in your system very long. Within 72 hours, it starts to be the levels start to go away. Within 2 weeks, any of the ingredients of the vaccine are no longer detectable, and the only thing lasting behind is the memory for your immune system and antibodies. That's about it. So it's very, very unlikely we'll have long-term effects. And I can't say that nobody can say anything 100% certainly, but what we can base it on are prior non-living vaccines that haven't shown, some rare side effects showing up 5 or 10 years down the road. I actually don't know the answer to this specific question. I have to look it up. Active mRNA versus non-active mRNA. I'm assuming that might mean that when the mRNA is delivered to the cell, it is either um, immediately available to start the process of encoding for the antibody versus non-active, where something else might have to act on it to activate that. Let's see. How does it? So So can you get COVID again? So the vaccination status will reduce your chances of reinfection. If you've already had COVID and you get the vaccine, you have the highest level of protection. Now, if you have gotten COVID, aren't vaccinated, and several months go by and your natural immunity can decrease, then yes, you could potentially get sick again. And the data that came out of the Israel study, and remember, there's still a preprint, it's not peer reviewed at this time, and there might be some changes to the analysis that comes from that, but um, their data suggests that natural immunity can last a good bit of time, and that's great news. And we've always known that the immune system can be great. But the problem is that information is based on infection from the Delta variant, which seems to replicate faster. It will cause a higher immune response. So somebody who had the Alpha variant before might still be susceptible for two factors. One, time, since their alpha infection, if their natural immunity has gone away, they might be susceptible to infection again, particularly of a different variant. And two, they weren't affected by the Delta variant, which seems to be the one that elicits a strong immune response. So this comment, I see this stuff a lot. People will be deleted in 2 years with the booster. So, I mean, these kind of comments don't really make any sense. They're kind of unfounded. We don't have any data to suggest that these vaccines have caused any harm. And based on other similar vaccines in the past, the non-living vaccines, we've never had any issues. So comments like that don't make much sense. Okay, the world top leading virologist disagrees with you. So if you can say what exactly I said that they disagree with me about, I'm happy to explain further. Um, So why would natural protection go away? So just like with other infections that we get, our body is not always meant to remember it forever. Certain infectious processes will have great long-lasting immunity. Other times they don't. So for example, I've used the example of tetanus before. So you get exposed to tetanus, you have what's called a sub-immunologic response. Your body might recognize it. Some might mount a small immune response, but it's nothing that will protect you in the future. And even for that exact event going on, that in disease process currently within you, you have to go to the hospital to get the tetanus toxin antibody or antidote. So if you don't do that, you'll likely die. And even though your body's been exposed to it and you mounted somewhat of a response to it, it's definitely not enough to protect you from that current event or re-exposure. Now with COVID, you do have natural immunity, and it does seem to be effective. But the question was how long, and we still aren't exactly sure. But it seems to be within a few months, antibodies start to go away. Now, that's not everybody. There will be people out there that have antibody responses that are shorter than a couple months, some that last for several months, maybe even a year. I can't say for sure with that. But the problem is there's no predictability when it comes to that. Now, with the vaccine, it's more predictable. It seems that there could be several months of lasting immunity, 8 months plus. Now, some people with natural immunity might have longer immunity than that, maybe a more robust immune response. But the people that get vaccinated don't have to get sick to get the immunity. Which shot is better for my age group? I'd have to look at the exact details for that, but from everything I've seen, I don't think there's a preferred shot based on age bracket, but you can always talk that over with your primary care physician and also any other comorbidities you might have. But for the most part, I don't think there's a preferred brand or manufacturer. VAERS shows over 13,000 deaths. So So the thing is, VAERS can be great. It's great to collect data, but you also have to remember that correlation does not equal causation. So say somebody gets a vaccine and unfortunately they pass away. That doesn't mean that the vaccine caused it. We've been vaccinating patients for 8 months now, and these self-reported deaths could be from other things besides the vaccine. If the rate of death is not higher than what we're seeing in the general population, then you can't say that it's due to the vaccine. The other side effects you can go and see, there's an entire list of them, and they're literally self-reported. Some people put anger on there and other issues like that that don't really make much sense to be listed as a side effect for the vaccine. And also, even if that number is accurate, and that's in comparison to 600 plus thousand American that have died from COVID, as well as millions around the world. And also, you have to remember that we've given out millions and millions of doses in the United States, and I think it's over 2 billion doses of the vaccine total in the world now. So the chances of death from that, even if these could all be contributed to the vaccine, which they can't, that's still a very, very low chance of dying, and it's even lower than the healthiest person dying from COVID by far. So your risks of taking the vaccine are exceedingly low. Your benefits are great for yourself as well as everybody else in society and your community around you, and especially compared to the risks of COVID and death from COVID. I defend the suppression of information. I don't really understand where that comes from. First of all, I've talked about evidence from both sides, and I don't really see where we're getting suppression of information. People have openly talked about studies that have either been positive results or negative results for things that can help with COVID. I believe there's been good transparency in the medical community with the results of trials, and people have been openly talking about it. Now, whether people agree with it, that's a different story, but we've objectively analyzed the data for this, just like we have objectively analyzed journal articles and stuff throughout our whole careers, leading scientists around the world, publishing their information, people trying to come out with protocols and guidelines to help with the pandemic. So I don't understand where the suppression of information argument comes from. You don't have data that these vaccines cause harm. Is your head in the sand? So that doesn't make any sense. I mean, I'm aware of the VAERS information and the fact that things get reported. And I'm not saying that none of them are due to the vaccine. I'm just saying that um, when you are looking at a treatment or a prevention, such as a vaccine, you have to compare the probability of a complication from the vaccine, as well as looking at the complications that can come from COVID. And that's not just death, that's also long term problems. One third of patients are getting neurological complications, including depression, but also other problems with their brain and spinal cord, pulmonary complications, heart complications, renal injury. Blood clots can happen from COVID. All of these things are significantly higher than what you're getting from the vaccine. And this is what I'm saying. So the thing is, when we're talking about the VAERS information, obviously 13,000 people dying is horrible. Whether it's due to the vaccine or not, that's sad. But we also have to make sure that when you're analyzing the data, that you're not just saying things happen coincidentally. You have to have a causal relationship. And like I said, if things are not happening at higher rates than what you're seeing in the background general public, then you can't attribute it to the vaccine. That's what you look for in regular studies. My thoughts on ivermectin. I'll just shortly say this. I've gone through that in more detail, but our large studies just show that it doesn't work. Large meta-analyses, the stuff that Dr. Corey, both in his testimony as well as his meta-analysis, included fraudulent information from one study. El Gazer, I believe, was the author of one paper, and that got retracted for plagiarism as well as fraudulent data. And that was used in a couple of meta-analyses, and that was one of the strongest trials supporting it, and it wasn't correct. When they took that out, a lot of the meta-analyses that did that showed very little benefit, and most of them showed no benefit. Now, the other side of that was Dr. Corey and their meta-analyses didn't remove it, despite it being fraudulent. So it begs the question on why they didn't want to have that study removed, and it's likely because it was the only one that showed benefit, even though it was fraudulent. Now, they also didn't disclose in their disclosure section of the meta-analysis that many of the authors were part of BIRD, and I don't know the exact acronym, but I believe it's the British Ivermectin. Um, it's not research, but development. And basically, their whole goal is to investigate the effectiveness and implement ivermectin. So they had a conflict of interest, and that's one of the biggest red flags in the study is that if somebody does not um, disclose a conflict of interest during a trial, that's a huge red flag. They have ulterior motives, things to gain from that, and then not to mention that some of these individuals that are touted as being against the pandemic have been people that have had their medical licenses removed even before the COVID pandemic. So don't come at me with they're trying to suppress them for COVID. These people were in trouble before COVID happened for Medicare fraud. One person impersonating somebody from Baylor University. So there's the list goes on for these individuals, and they have conflict of interest in Dr. Corey's case, and he's also selling ivermectin branded merchandise on a website. So he had conflicts of interest there, and there is I forget her name, but another prominent anti-vax physician. Uh, she was selling courses, basically almost like a multi-level marketing scheme for people to talk with her for like $600 or something like that. So these people were making money off of the pandemic and trying to sell courses. Those are all red flags. People that are doing clinical research should not be doing it for monetary reasons and capitalizing off of their position like that. Then why are they doing studies on the vaccine? I mean, so they're doing studies on the vaccine because it's basically a medication, it's a vaccine. So anytime somebody develops a treatment, a vaccine, or anything along those lines, it has to go through safety and efficacy trials and then FDA approval. And the only time that something I wouldn't say rushed, but allowed to be used sooner was under emergency use authorization. And the reason they did that was because so many people were dying. And at that time, it was for the greater good, and they still had already had 2 months of solid data, and then they re-reviewed it, and it got full approval after there was a year of data available. So why can't vaccinated patients donate blood? So you can go to the Red Cross website. I'm not sure I think that was a theory before that there was some issue with convalescent plasma or donating platelets, RBCs, or just FFP, but that is no longer an issue. They do discuss it on the website, and if you have individualized questions, they do have frequently asked questions on there regarding your ability to donate. And if you have questions, you can call the Red Cross directly. But for the most part, by and large, people can donate. And if you want to donate, that would be extremely helpful because there have been problems um, with the levels of blood available because of COVID affecting donations. All right. Let me answer one more question, then I'm going to go. Let's see here. All right, so somebody just asked about vitamins. So unfortunately, I mean, you can take your recommended daily dosing for most of your water-soluble vitamins. Your vitamin C, most of those things will be fine. Zinc, magnesium, anything in excess, you're likely just going to urinate out. Magnesium can get a little, can be toxic at very high doses. Usually it's fine with oral supplementation. Your body will excrete that. Now, for fat solubles, vitamin D, you can have problems with that. That is a fat soluble vitamin. It will accumulate in your body. You can get kidney stones, neurological problems such as confusion, and it can have arrhythmias for your heart if it affects your calcium levels. So you have to be very cautious with those. But for the most part, unless you have vitamin D deficiency, which takes weeks to replete, most of the vitamins you would take are not proven to reduce your chances of getting COVID. I'm not saying that optimizing your immune system is not a smart thing to do, but taking a certain regimen has not been proven outside of those with deficiencies to be beneficial. So I hope that helps, and I hope you guys have a great rest of your day. For those that are vaccinated, thanks for doing that. It's a great help to everybody. And for those that are unvaccinated, I hope you still stay safe. And for those on the fence, I hope that I'm able to provide you with information so that you have the ability to be fully informed to make an informed decision. Either way, I hope everybody stays healthy and have a great day. Okay.